Our next speaker will be Dr. Leong-Sit. He's an associate professor of medicine at Western University and a member of the London Heart Rhythm program. He completed medical school at the University of British Columbia, an internal medicine residency at McMaster University, a cardiology fellowship at Western University, and an arrhythmia fellowship at the University of Pennsylvania. He also has a master's degree in epidemiology from the Harvard School of Public Health. His clinical and research interest in atrial fibrillation and ventricular tachycardia ablation, and he's contributed to 74 peer-related publications, 4 textbooks, and 4 book chapters. Dr. Leong-Sit will be discussing syncope and when to worry.
Thank you very much, and it's a privilege and honor to follow the speakers, the chair of the meeting, and of course one of my mentors at McMaster when I was there, Gord Guyot, with a very provocative talk. Today I've been given the charge of talking about atypical presentations of syncope. It's always a challenge when you're trying to talk about the zebras, as the first talk did, but try to keep it relevant for your day-to-day practice, since these are zebras and they're rare. So I do have a few take-home messages at the start, and then I just want to expose you to some of the more rare entities so that you know what's out there. And I think the more you're familiar with the zebras, the more comfortable you are with the horses. Okay, so I'm going to start with a case one to whet the appetite. We have a 42-year-old. Everyone here has syncope patients in their practice. We get lots of syncope referrals. In fact, for the last 6 years or so, I think I've been presenting mostly on syncope at our workshops here, and it has this interest that even though I try to do other talks, I've always been asked to talk about syncope, and that's because it has a lot of interest and it has a lot of fear, and that's because we're afraid of the more rare but dangerous things appropriately. And so we have a 42-year-old with a brief blackout. He's had prior lightheaded episodes for the last 9 months. This last event occurred while he was playing soccer with his friends. His past history is rather benign. He has had prior knee surgery, otherwise healthy, and he's just on some Tylenol. So this is a peek into how we view things. Who needs to be investigated? I've shown this slide several times, but essentially you could see that the vast majority of syncope is benign, at least from a cardiac or mortality standpoint. Of course, it has lots of morbidity even when it is vasomotor syncope, but the thing that bothers us and keeps us up at night is, am I missing that rare thing that might cause sudden death? Am I going to discharge the patient from my office or from the ED, and they're going to be found dead the next day or the next month? And so that's what worries us. But of course, we can't do $1 million workup on every patient with syncope because, by and large, the vast majority of syncope is benign. And so what we do is we try to make a decision based on their story and the typical nature of their symptoms. The more that they subscribe to the typical features of vasomotor syncope, the more that we do not have to investigate them. The more red flags that they have, the more atypical features, the more that we have to engage them and investigate them further, even if we still think that they might be vasomotor, and most often end up being that way, but we want to make sure we're not missing the rare but dangerous things. And so the more that the history lends us towards vasomotor, the less we have to investigate them. For instance, the 16-year-old who goes and has blood work taken, they get nauseous, they throw up, and they faint. I don't think anyone needs to do an echo or a stress test or fancy tests. Everyone knows this is going to be vasovagal syncope. But this is the mindset. The more atypical features they have, the more you need to investigate them. It serves to talk about when not to worry rather than when to worry, because despite being the secondary, tertiary specialists that will see the syncope, I would still say that 90% of the syncopes sent to us, probably more, end up being vasomotor. And often it's quite obvious when we see it every day that the story could have got us there. But to everyone's comfort level, It's to their comfort level of whether or not they're seeing enough typical features that they're okay not investigating them further. And for each individual physician, that threshold will be different. So vasomotor, these are the things that everyone here knows, and I don't want to insult anyone's intelligence, but just like the ACLS protocols, which everyone knows, if someone's unstable, shock them. There's a difference between the guidelines and when the patient's in front of you. For everyone here, you remember back in the hospitals when you were running the codes, unstable shock, you could say that on your exam and be 100% correct, but when that patient's in front of you, are they actually unstable enough that they need that shock? A much more difficult decision. And same with the messages on this slide. Everyone knows these messages, but it's much harder to make the decision when that patient's in front of you and you have to make the judgment. So most often upright, can occur while seated. There are common triggers, but there are very commonly not triggered. The common triggers we see, postprandial, warm day, prolonged standing, post-micturition, post-cough. These are all the textbook things that all of you know well. The prodrome can sometimes be associated with fatigue, nausea, sweating, pallor, visual disturbances, abdominal pain, and lightheadedness, but often it isn't preceded by that. And so the more of these features they have, the less you have to go forward with further investigations. And this is sort of just a visual representation of how we see it. The more typical they are, the more likely it is vasovagal. But even when the symptoms are atypical, like on the left-hand side of the screen there, I would say most of them still end up being vasovagal. But because that percentage of dangerous causes of syncope is higher, we do need to pay more attention and make sure they're not in that red zone. So here are some extra questions to ask. If you ask the patient, did this happen suddenly? Everyone knows to watch out for sudden syncope. I will guarantee you everyone will say yes, it happened suddenly. And that's because the patient doesn't know what you mean by suddenly. If it happened over 2 minutes, well, that's suddenly for them because it didn't happen yesterday, but it happened over a couple minutes today. So I think a better question to ask is, what's the last thing you remember before going down? Did you have a chance to brace yourself? Did you know something was about to happen before it happened? And that gives you more of a sense of, was it really sudden or not? If they say, yes, it was sudden, I tried to run to my bedroom, but I didn't get there, well, that means there was a prodrome, and you know that they had some warning. So the ones that really get us worried are the ones that lead to injury, because that usually speaks to the fact that it did come without warning, or they didn't know how to respond to protect themselves. So back to our case. He was playing beer league soccer with his buddies. He was chasing the ball, and he says the last thing he remembers was dribbling the ball, and he found himself on the ground. His teammates were around him when he awoke. So I hope everyone recognizes this is not benign syncope, okay? I'm trying to make a clear point here. A lot of people will say, I fainted when I was jogging, and it raises your alarm bells. But when you ask them, what were you doing right before? What's the last thing you remember? They say, I was going for my 5-kilometer jog. I stopped at the crosswalk waiting for the light to turn, and then I fainted. So that's post-exertional. That's not during the actual exercise. Post-exertion is very common for vasovagal, but during exercise has to be malignant until proven otherwise. So here we're going to talk about a few of the rare entities of atypical syncope related to exertion, because that's the first message. If it happens with exercise, during exercise, this absolutely requires further investigation. So here are the key differentials. There's the mechanical ones that are easy to diagnose, and that's because there's some sort of obstruction, like aortic stenosis or HOCM. And then there's the arrhythmogenic ones, long QT, coronary disease that could cause VF, CPVT, ARVC. So I'm going to show you a couple slides on just these various entities so you have some exposure. So aortic stenosis, everyone's aware of because it's common. You're going to have a systolic ejection murmur when you put your stethoscope on the chest, and that's because the aortic outflow is going to be reduced. And so it can't increase the outflow to the extra demands when there is exercise, and so that's how aortic stenosis could cause syncope. Hypertrophic obstructive cardiomyopathy can do a very similar mechanism, but it's through thickening of the septum and that muscle there right under the aortic valve. But same principle. When the outflow is obstructed either by the valve itself in AS or by the muscle underneath the valve, like in hypertrophic cardiomyopathy, then the blood flow cannot respond to the needs of exercise. So these are the two things that you would easily find with echocardiogram. And so these are the clinical findings. If you hear a murmur of any sort with syncope, our clinical skills are becoming more and more eroded as imaging tests get more and more commonplace. But if you do hear a murmur in someone with exertional syncope, that's an absolute red flag. So the bottom line, murmur and syncope, get the echocardiogram and exclude these mechanical causes. On to the arrhythmic causes. Here we have an example. You could see at the start of the trace, it's an inferior ST elevation. So this person's having a myocardial infarction. What we're worried about is, can there be ischemia or infarct causing ventricular fibrillation? And so that could be provoked by exercise if they're having active ischemia. And so that's another thing that you need to work up when you have exertional syncope. So getting their history on cardiac risk factors, on exertional chest pain, did chest pain precede the syncope? These would be the important factors. And the investigation would be an ischemic workup, whether that's a treadmill test or going on to a nuclear test or coronary angio. Here are more rarer birds out there. This is just a demonstration of a funny ventricular tachycardia that you can have during exercise. And you could see that it's alternating morphologies. This is called bidirectional ventricular tachycardia. Not for you to remember because you likely won't see this in your careers. But this is a genetic abnormality in terms of the calcium handling in the heart. And these people have polymorphic ventricular tachycardia induced by exercise or adrenaline. And so, once again, the key feature is exercise-induced syncope, and we're worried that it could be polymorphic ventricular tachycardia. You would ask for family history of unexpected sudden death because it can be autosomal dominant or autosomal recessive, and our first test would be to exercise them and see if we could provoke VT. And so this needs to be in a setting where you can respond if they do go into VT. So that's always a hairy test when you have a high suspicion. Here, another rare entity that you may or may not see in your careers. There is an abnormality on this ECG that is subtle, but clear if you know what you're looking for. Here we see in the right precordial leads, there is a little bit of an electrogram abnormality right at the end of the QRS. This is one of the signs of arrhythmogenic right ventricular cardiomyopathy. It's called the epsilon wave. What this is fatty fibro replacement of mostly the right ventricle, but could be both ventricles, but it's preponderance to the right. And it has a rare prevalence, but this also predisposes to exercise-induced ventricular tachycardia or ventricular fibrillation. So the key screening tests here when you're suspicious are the same tests that we repeat over and over for the others. So you could see even though these entities are rare, the testing is clear. When you have exercise-induced VT, syncope, you need to get an ECG, an echocardiogram, and maybe even further imaging. And I think this is the last one in this case here when you have abnormal ECG like this, which may be more or less obvious to those of you who look at ECGs more or less commonly. But I think the most obvious leads in terms of abnormality would be in the inferior leads there. You could see just how long that T wave goes. And the general rule of thumb is to see if that T wave ends before the halfway mark between the QRSs. And that's because that QT interval will change with heart rate. So as a general, very rough rule of thumb, if that T wave goes beyond the halfway mark, then you should start paying attention to the computer-generated QT corrected interval. And so if you read the QT corrected interval, in general, be beware of syncope associated with a QTC of greater than 480 to 500. So 500 is an easy number for you to remember. There's a lot of overlap between normal and abnormal, but certainly we would pay a lot of attention if it's above 500. And the C refers to corrected for heart rate, so it's normalized to the patient's heart rate. This is what we're worried about in long QT. They have a PVC, as you could see on the second bead of the screen, on top of the T wave. That's called the R on T phenomenon, the R wave on top of the T wave. And in that case, it led to just another PVC. But then in the middle of the screen, it lands at the wrong place at the wrong time and sets off a short non-sustained run of polymorphic VT. And so this could lead to syncope if that polymorphic VT lasts long enough. And this could be a very scary thing to manage acutely. So summary of case one, syncope after exercise is common. Syncope during exercise is the first take-home point, is high risk, absolutely needs investigation. Consider mechanical and arrhythmia causes, but the first tests are common to many of these entities, and that's ECG, echo, possibly a treadmill test. Case number two. We have a 62-year-old man with a fall, unsure if he's tripped. He thinks he may have blacked out. This is the usual story. He doesn't give a good story, and you're left with not much to work with. So how much do we work up this patient? When the syncope is sudden and you ask the patient, what's the last thing you remember? And similar to the first case, I found myself on the ground. I had no warning. That's the classic Stokes-Adams attack. So the second red flag is sudden syncope, even if it's not related to exertion. So the more sudden it is, the more we're worried. Certainly, we have seen many vasovagal syncopes that occur suddenly. So this doesn't mean that it's absolutely malignant, but it deserves increased attention. So the best first tests are going to be the same, the ECG and the echocardiogram, but let me take you through a couple of the entities that we're looking for. So on the ECGs, we're looking for signs of undiagnosed risks of heart block. So do they have a bundle branch block? Do they have signs of previous undiagnosed coronary disease like Q-wave infarcts that may have been subclinical? Do they have systolic ejection murmurs, etc., that may lead to mechanical causes, just like with exertional syncope? The more signs that they have of structural heart disease, the more that the echo needs to be done to rule that out. In general, structurally normal hearts have a low risk of malignant tachycardia. But here are some of the situations where you might have suspicion for what the diagnosis is here. So here you do an ECG on this man with sudden syncope, and you see an abnormal ECG. It is indeed sinus rhythm, but you could see that in V1, there's a right bundle branch block. In leads 1 and 2, you could see that there is also a left anterior hemiblock, so this is called bifascicular block. You could also see that there's a very long PR interval. So this man's conduction system is diseased, and even though we don't like the term, we could call this tri-fascicular block, and that they have clear disease in their AV node, their bundle branches, and so while this ECG being asymptomatic isn't an indication for a pacemaker, this ECG in someone with syncope NYD should put heart block or transient heart block to the top of your list. And so if you rule out other causes, then this is a reasonable empiric pacemaker if the syncope is suspicious. So no investigation is needed if asymptomatic, but an empiric pacemaker or further investigation is reasonable for bifascicular block, high conduction disease with syncope. Here is a rare thing as well. Most of you may or may not see this, but in V1, V2, you have this funny ST elevations that look like a ski slope. And so this is called the coved ST elevation and right bundle branch pattern of Brugada syndrome. And so Brugada syndrome, when it was first described, everyone got excited, thought it was one of the most dangerous things. And then as with most things, once you start screening for it and recognizing it, the overall risk goes lower and lower as it's more and more recognized. And so this is a channelopathy with a sodium channel in the heart, and it could cause various morphologies of these funny ST elevations. Sometimes it's thrombolyzed or brought to the cath lab, even in the absence of chest pain, because it's not recognized as atypical ST elevation. But these can lead to VT or VF. So syncope triggered by fever is the hallmark for Brugada, and not to be confused with the fact that many times vasovagal syncope will be after you're dehydrated or after an illness. So a bit of confusion there. But if it's sudden syncope, they have a bad ECG with ST elevations. I don't think any of you will ignore that and send that for further investigation. And I think finally here we've got sinus rhythm, and I hope people can see that this is a short PR interval with a slurred upstroke of the QRS. So many of you will recognize this to be Wolff, Parkinson, White syndrome. Someone has sudden syncope and they come in with a WPW ECG. Once again, there's a need for attention. And the entity that we're worried about is if they go into atrial fibrillation, this extra accessory pathway connecting the atrium and ventricles may not have the usual speed limit that our AV nodes do to protect us from very rapid rhythms. And so if the accessory pathway happens to be a robust one and their atrial fibrillation atrial rates are at 300 or 400 beats per minute, if most of those go down to the ventricle, even in a healthy heart, that heart will begin to ventricularly fibrillate. And so that's the worry. And if they sustain these rhythms of 250 to 300, then they could have a small risk of sudden death. And so a syncope patient with WPW is a more urgent assessment that's needed. So the final quick case is that having said all those things, it's going to be very common that those situations aren't the ones you see. You're going to see the run-of-the-mill have some of the typical features of vasovagal and have some atypical features. So I'm just going to leave you with one bottom line. Anytime you are worried and you're not sure where to go further, the initial tests have been normal, but you're still unsure. And a good example would be someone was driving their car, they crashed it to the side. You can't ignore that. You do the ECG, you do the echo, it's normal, it's normal. You do a treadmill test, it's normal. Now what? Yes, it's challenging on one hand, but on the other hand, the steps forward is clear. You need symptom rhythm correlation. So anytime we're dealing with a gray zone case, you need a monitor to be on the patient's chest if they have it again. And so I'm speaking to this because everyone orders a Holter monitor, but the vast majority of monitors that come back to us when we have a syncope workup is not during symptoms. And so you find all these incidentalomas. And so what you need is a monitor during the symptoms. So the more frequent it's happening, the easier it is. If it's happening every day, a Holter is perfect. If it's happening once a week or once a month, a Holter isn't going to do the trick unless you have a 2-week Holter or a 4-week Holter. So you need a monitor at the time of symptoms. And we do have implantable loop recorders that have a 2 to 3 battery life. So even when it's something very rare, if we are worried, like in someone with an MVC, we could implant a loop recorder so that we could record if it does happen again. I'm just going to skip through my favorite slide here, which I've shown many times, but this just speaks to when you tell the patient to make a diary of their symptoms. It's not a real diary, so here he's saying, doing my wash, nothing to report, can't imagine what made me so dizzy last Thursday. When we talk about a Holter diary, you want them to record their symptoms of concern. And so we don't care about their headaches, we don't care about their palpitations or chest pain if the workup is for syncope. So you have to be clear with the patient. Push the button when you have the symptoms we were working up, not other symptoms. Hope I have done this okay. So here you could find someone with heart block on the loop recorder and you could implant a pacemaker. So symptom rhythm correlation, don't be distracted by incidentalomas. In summary, vasovagal syncope is largely a clinical diagnosis and by far the most common. Remember the red flags I pointed out, sudden attacks, if it happens during exercise, if they have known cardiac or family history, and the key initial tests, ECG, echo, treadmill, and if it's exertional, make sure that they do get a full workup, and symptom rhythm correlation is your friend. Thank you.